Cast is now starting. All attendees are in listen-only mode.
Good evening, everyone, and thank you for joining our webinar tonight on anorectal physiology testing and rehabilitation by Dr. Rebecca Calley. During the webinar, if you have any questions, you may use the question panel and type it in, or you can raise your hand, and about halfway through the session, Dr. Calley will answer the questions, and I can either read the question from the panel or unmute you, and you can ask the question. So here we are with Dr. Calley.
Hello, everybody. I'm going to just tell a little bit about myself and why it is that I enjoy talking about this subject so much. So I trained at Creighton in the early 90s and completed a 2-year colon and rectal fellowship. The first year was actually important because it was all about research, and they had a pretty nice pelvic floor lab. So I was. Oh, are we muted? I just heard something. Hello, Kim. Kim, are you there? I'm not sure if I can be heard because I just heard something say muted. Okay, it said muted or unmuted. Okay, anyway, so I was talking about my training, and so it really opened up a whole new world to focus the study on the pelvic floor or the anal sphincter, problems I'd never heard of as a surgical resident, like non-relaxing puborectalis and the effect of rectocele and prolapse, internal prolapse and external prolapse on people's lives. So I got a lot of training there. I went off to East Texas Medical Center. I'm sorry, not that one. I went off to East Carolina University first, and nobody did this kind of investigation, so I set up a lab, which was kind of fun, and pursued it further. Since I was the female in the area, and a lot of these problems affect females, it kind of lent itself to me getting all these referrals. But I was also really interested in it, and got more and more familiar. You know, after a while, you sort of get a gestalt about the way the patient presents, and you're already thinking ahead. You know, so and then. We moved eventually to East Texas with East Texas Medical Center, and again, nobody in East Texas was doing these studies, and so I worked with the hospital administration and set up for me, it works very well, and we get referrals from a pretty wide area around here. So what I'd like to do now is start with a quote that is interesting quote. It's by Dr. Walter Bornemeyer in American Journal of Proctology somewhere around 1960, and he points out that in the process of doing a hemorrhoidectomy, you really have to have a lot of respect for the underlying sphincter muscle, and he turns to this very descriptive prose, which we don't really use this kind of language anymore, but I thought it was fitting because it really does point to the importance and the special nature of the anal sphincter as compared to, in this case, the human hands. So let me read this to you. And if you've had patients who have anal rectal problems, whether it be pain or incontinence or a pruritus or something of that nature, they would too appreciate how important it is. It's the sort of thing that you don't appreciate until it goes wrong. But anyway, he said, and I'll start out above this quote that I have on the slide. He said, "There's not a muscle or structure in the body that has a more keenly developed sense of alertness and ability to accommodate itself to varying situations. And they say that man has succeeded where animals fail because of the clever use of his hands. Yet, when compared to the hands, the anal sphincter is far superior. If you placed into your cupped hand a mixture of fluid, solid, and gas, and then, through an opening at the bottom, try to let only the gas escape, you will fail. Yet the sphincter ani can do it. No other muscle in the body is such a protector of the dignity of man. a muscle like this is worth protecting. And I would add, of course, worth investigating. So off we go to investigating. First, you have to understand the anatomy, all right? So I'm sure a lot of, if there are physicians on the call, I'm sure they're very familiar with this, but it's still, even as a surgical resident, I did not have a great concept of this part of the human anatomy the way I do now. So maybe this will help. I always think of the anal sphincter as two almost cylindrical muscles, one inside the other. And the anal canal extends from the verge or pucker right here all the way up to the top of the anal rectal ring. Okay, now here the internal sphincter is, you can see this if you're looking at my little arrow here. This is the smooth muscle of the rectum, and then it condenses down and forms the internal sphincter muscle. So it is almost always contracted. Okay, that's something that's important. It's under autonomic control, not voluntary. It's primarily responsible for the resting tone, and that's one of the things we measure. With manometry, we measure a resting tone and then a squeeze, of course. So overall, it contributes to about 60% of the continence. Okay. The other 40% is from the external sphincter, but also hemorrhoids. The fullness of the hemorrhoidal tissue that's at the top of the anal canal does contribute some to incontinence. The very important thing about the internal sphincter muscle, it relaxes for a short interval in response to certain stimuli, most commonly distension of the rectum. It will relax, and then stool falls into this little funnel and is allowed to be sampled by the very, very sensitive epithelium there. Now the external sphincter. It is the outer cylinder, if you would. It's usually a tad bit longer than the internal sphincter, and the groove between it is a very important landmark for colorectal surgeons. So it's the outer muscle, and here's the groove. So usually when you do a digital exam, when you first insert your finger, you're feeling the ring of external sphincter. If someone has a fissure right in here in the anal canal, this muscle tends to be very, very snug, and we call it a very prominent intersphincteric groove. Why is that important to this talk? Well, some people who have difficult evacuation are going to have a hypertonic internal sphincter. And although we're going to test them and get all these numbers, the hard numbers, it's also important to compare that to your physical exam. So I like to correlate everything together, and so I'll feel the groove and say, is this super prominent, is this muscle super tight? So, but anyway, external sphincter. It's under voluntary control. It responds with a reflex contraction with increase of intra-abdominal pressure. Think about that. So otherwise you could be caught off guard and pass gas unexpectedly or even stool when sneezing or coughing. So it is innervated by the pudendal nerve, which is super important when we're evaluating incontinence because of, diabetics, any other kind of neuropathy that people might have, even neuropathy or a pudendal nerve stretch that results from difficult childbirth. The tone also increases with squeezing and decreases with defecation, obviously, or straining without defecating. It does have some long-term, some tonic contraction, so it's not 100% under voluntary control. It contributes about 20% to the continence. All right, so a little bit more about the anatomy. This is an image of the puborectalis sling. I say image because it bugs me a little bit that it's not as accurate. It does fuse with the top part of the external sphincter, which is this red cylinder. It helps maintain continence by creating an anorectal angle. Okay, the anorectal angle would be here, that angle. It's almost 90 degrees at rest in most people. This muscle is also supposed to relax. Okay, so if this muscle relaxes, it releases the rectum that way and allows it to straighten out and permit defecation. So I have here that it creates an 80-degree angle or so, which helps maintain continence 80-90. All right, next. Okay, let's look at the process of defecation. This is a busy slide. It has a couple parts to it. All right. So the first thing, think of the gastrocolic reflex. You fill up your stomach, and then what happens? You'll get distension in the left colon from stool. It initiates a peristaltic wave and propels the fecal mass from the sigmoid into the rectum. All right, like that. So a lot of things happened on this slide. First of all, when the rectum gets distended, it induces relaxation of the internal sphincter muscle, okay, and reflex contraction of the external sphincter. Okay, that's a good thing because you may not be ready to evacuate right then. There's also this is a rectoanal inhibitory reflex, by the way. It also creates a spinal cord stimulus of the cortex, which is what we call the first sensation. Okay, so there's first sensation like, is not quite ready to go to the bathroom, but you're aware of it. This rectoanal inhibitory reflex that I was referring to right here, or the RAIR, if we call it RAIR for short, it permits the rectal contents to come into contact with the sensory epithelium of the anal canal, which is down here. I was alluding to that just a minute ago. That area can discriminate the temperature, pain, and light touch that we were talking about in that first quote. Now, this can be followed by voluntary contraction of the external sphincter if you need to delay defecation. Then, if not, the process of defecation goes on further with relaxation of the external sphincter, there you go, and puborectalis, contraction of the abdominal wall, here, isn't that nice? And an increase of the anorectal angle with emptying. So right there, so the anorectal angle increases, and you have the desired result, if you would. Okay. All right. So you have to remember all of that in order to really understand what the process of testing does. So why do we do anorectal testing? Where is it going to help you figure out what to do for the patient when everything else hasn't? And maybe they've had a colonoscopy and they've had physical exam and they've had a BE maybe, but nothing is really sorting things out for you. Well, in some places it's going to help is fecal incontinence, okay? Constipation, that sounds like outlet dysfunction, where the patient says, it's right there, and I sit and nothing happens. I get up and walk away and come back. That's one of the things I like to hear to really think about definite outlet dysfunction. Or I have to rock back and forth. This is usually women. Yeah, I mean 90+% of the women, of course. A combination of both, outlet and fecal incontinence, is a red flag for internal prolapse. Okay. So also anorectal pain, and I will be honestly tell you it's not that common that we do this for anorectal pain, but anorectal pain can also be a sign of a fissure or something like that. That could, again, I mentioned before, result in hypertonic internal sphincter that causes outlet obstruction. You can do it as a baseline evaluation before operation. I've had referrals for before colostomy closure when maybe the patient had a rectal injury or had other issues with their anorectum before the colostomy was done for whatever reason, after very low anterior resections and things like that. You can use it to evaluate a rectocele and rectal prolapse, rule out Hirschsprung's disease, especially short segment Hirschsprung's disease, which is about the only kind that you're going to find in an adult. And also anismus. Anismus, the word I learned in training was non-relaxing puborectalis or anismus, where you just get that puborectalis does not relax and allow the angle to increase. All right. Study preparation, this is sort of intuitive. The rectum has to be empty because you have the catheter, it's going to get plugged up. So a light dinner the night before, no breakfast, and an enema if it's in the morning. Digital exam should be done, and it's good to record that, and then you can use it to compare to your values. Also define the anatomy. Is it a short sphincter, long sphincter? Is it, your impression about the weakness of the sphincter, rest and squeeze and push. I have them do that right before we do the manometry. And I just said that. Coach the patient also to be sure they're doing it right. So is a squeeze really a squeeze? Sometimes a squeeze is a push and you can feel your finger being extruded. And you say, no, not that. Try again. Squeeze, pull up. Pretend you don't want to pass gas. So you use all kinds of sayings like that to get them to understand what you want. The various investigations, EMG recruitment, we use surface electrodes, not needles. Used to use a anal canal plug, but the surface electrodes work well. Then there's a stationary pull-through manometry, and I know a while back we had the little machine that pulled it through. I never had confidence in it because I think there was too much variability as to what the level the sensors were at. And this way with a stationary, you go centimeter by centimeter, and I actually look every time just to be sure it's in the right spot. Rectal anal inhibitory reflex, we talked about. Balloon sensation or compliance. It's hard to call it compliance because it's not a closed lumen. It's an open lumen. Balloon expulsion and pudendal nerve latency. All right, preparation for the EMG and for everything. EMG and manometry are done. Whoa. I'm sorry, I thought I turned that. I thought I had that on silence. Okay, it is now. The patient's in the bed in the left lateral decubitus position with the hips and knees flexed. So I say, pretend you're sitting down on a commode, but you're just lying down on your left side. And I always do the EMG first because that the skin is clean. Wipe it off. I don't do a digital exam first. And then there's electrodes which go on either side of the anal verge, pretty much as close to the verge as you can get them. And then a grounding pad, which is green. This is a EMG normal pattern. So you want the voltage about 4 or less for resting, and the squeeze above 15. So some people you'll get it way above 15, which you can correlate with other stuff, but really 15 or higher microvolts is normal. And the push should be close to the rest. Theoretically, it should be lower because you're evacuating, but really, if it's close to the rest, that's fine. And that's what the report, I include one of those in the report. So for the stationary pull-through, it's the same position. Then you insert the catheter to 6 centimeters, and that means that the sensors are 6 centimeters above the anal verge. And I don't think I've ever seen a sphincter muscle that's 6 centimeters long. So you start out in the rectum, all right, measuring in the rectum. There's a line on the catheter, and you orient it to the posterior midline. Okay, and then there's a very nice booklet that you can follow step by step, and I have a nurse do it because I'm not coordinated enough to click the little remote all the time. But anyway, so that I have my hands on the patient. And this is what a stationary pull-through, just one section, looks like. So this would be one quadrant at one level. You have the rest. And of course the squeeze goes up, and the push should be, again, close to the rest. It kind of looks like the EMG, but just in pressures. The sensation test, the catheter is inserted to 6 centimeters because you want this balloon to inflate in the rectum and simulate a stool bolus. And you ask them, as you slowly inflate with air, you ask them, when do you feel something, anything? So you may feel an air bubble, a little pressure. Remember that rectal anal inhibitory reflex elicits that first sensation. Then when do you feel that you're going to have to start looking for a bathroom? Okay, and the maximum tolerated volume is, if you're talking to somebody and you feel this urge, you have to say, excuse me, I'll be right back. So, and they have normal ranges for that. normally around 20. It's kind of variable. Again, if your numbers don't fit exactly into the ranges, you'd look at the whole picture before you make an impression that they have bad sensation or hypersensation. So looking at all of the things that we just talked about, this is the tracing that you get. There are 4 quadrants that are measured. And let me just look at this. This is up at 6 centimeters. Let me orient you guys. 6 centimeters, 5, 4, 3, 2, and 1. Then the next is the rare. And then the next is a sensation. And this is a balloon expulsion. So if I just look at this one, I'm looking at the baseline. Just look at an overall baseline. I think the green one's best here. Overall baseline. And you see that the baseline increases at 2 centimeters. So the high pressure zone in this patient, or probably the main part of the internal and external sphincter canal is about 2 centimeters. And the rectal inhibitory reflex is present. I asked you to note this, you inflate the balloon and then deflate it very quickly, and that stimulates the stool bolus. And it's very nice because you usually do see that increase in pressure. That's the reflex contraction of the external sphincter. Then you see a relaxation here. And you do in all of those. All right. This is the stationary pull-through that's just spread out a bit. And again, let me go over this part so that you can follow the case studies with me better. So you have the rest in the blue. You rest for 7 seconds. I tell them just rest, and she'll push rest, okay? And then it automatically measures it. Then I'll say squeeze and relax, all right? And then push, push, push. Okay, I want to show you something here. The push pressures are going to be high, and indeed higher than the squeeze pressures. Where? Above the sphincter. Why? Because it's in the rectum and the rectal lumen, and it's getting the pressure from the abdominal contractions. Okay. Now, when the sensors are in the middle of the sphincter mechanism, they're sort of protected from that effect. And here you get a little push, but the squeeze should be higher. And, this one isn't quite that impressive. Let me take the 4 centimeter mark. The squeeze is higher than the push, and that's what it should look like. All right, next, this is with it really spread out, just showing that you can do that. And again, the rare, we talked about that on the first one. And the sensations, I don't usually use this part of it, but theoretically the pressure should go up, obviously, as the balloon gets bigger. This is a nice report that I include along with that EMG report with what I send back to the referring docs. And this is a miniature of that report with all of the numbers. And the numbers measure the resting. And I know this says squeeze, but that's wrong. I always cross that out. This resting pressures. And you can get a pressure increase, which is in the differential between the rest and squeeze. But I really need to look at this one for squeezing, amplitude relative to 0. So I'll look at the summary here, the averages. I'll look at the maximum average, here 47 for the resting. And it's not really, interestingly, it says, I think, 63. I can barely see it. The squeeze should be about twice the rest. Here it summarizes the sensations. And here the rectal anal inhibitory reflex and balloon expulsion, if it's present, partial. This says partial, I think. So that might not have been a normal test. But it's very nice to have it all summarized, and you can draw conclusions from that. The pudendal nerve terminal latency, this is the unit that you use. You can check the right and left pudendal nerves with a St. Mark's pudendal electrode. And it delivers a stimulus and then records the latency with that all through the same strip. There are little wires embedded in that plastic. So that's a stimulus there, and this is the response. and then they measure the distance here. You don't have to do anything. It measures it automatically. So here's the screen, and 1.8 to 2.2 is a normal range, so these may be actually out of range. And the left side is going to be have an upward deflection, and the right side is going to be like the mirror image of it. And so this test is useful for checking pudendal nerve damage. The problem I used to have with it is that if their pudendal nerves were so bad that you couldn't get a twitch, it's hard to really pick them up. So it's very useful to say that it's normal, as with most things, but it's hard to say how abnormal it is. You can just report that it was not obtainable sometimes. Going back to the manometry, this is a catheter. It's disposable. It works very well. I've had very few malfunction. It's not very expensive at all, so I think it's nice to have it disposable. Nobody has to clean it. And the balloons at the end, the sensors are right there, and it goes up to about 6 centimeters, which is right there. So it's color-coded, so you know exactly where to put in the lure locks. Now this is, sensitive mouse here. Yep. Excuse me, just a second. Okay. So high-resolution anorectal manometry is really the way a lot of people are going right now. What's nice about that is you get the visual just in all one image. So I can tell you this is great. This is a high-pressure zone here in the red, and the cooler colors denote less pressures. And the other thing, we used to do something called vector symmetry when I was in training, but this is a no-brainer. You just look, if there's a defect in the muscle, you'll see a nice notch, a nice piece of the pie cut out, if you would. But you will get, you have these tracings that are the way routine manometry is done, and it's just changed into something that's more visually impactful, if you would. So this is the strip that you get with resting, squeezing, and push. There's endurance squeeze there of the anal canal. And again, another report with the 3D image reconstructed there. The catheter for the high-resolution anorectal manometry is a solid-state catheter. All right. And also with 4 ports. I have these normal values here because we're about ready to go into the case studies. And if you are, to have a better level of participation, if you don't mind, if you have a piece of scratch paper, just write down some of these numbers. Like resting pressures are 30 to 40 millimeters of mercury squeeze. See, it's about double, 60 to 80. First sensation between 20 and 35 milliliters. First urge 120 to 150. Maximum tolerated volume 200 to 300 cc's. EMGs, we already talked about it. I'd say below 4 is normal for rest, above 15 for squeeze, and the push should be about the rest. Okay. And this might be a good time, Kim, to see if there's any questions and be sure that people are following me before we go into the case studies.
There was one question that came in while you were speaking. The question is, well, this was a few slides ago, but the question was, what if they have an afternoon appointment and they are diabetic? Should they still not eat?
Now, you know they can drink. What really stimulates, what really ruins it is if you have I'll just tell my patients, I need the last 8 inches of your rectum empty. So what stimulates it is a big lunch. So they go for lunch and they get that, you remember that slide with all the motion on it, they get that contraction, they're going to push stool down into the rectum. So it's just, a couple Fleet's enemas. And if it's a lunchtime, and I do a lot of mine in the afternoon sometime because the fluoro units, I do defecographies too, and that unit's being used. So I will tell them, eat your breakfast, then do your Fleet's enemas, come on in, And you can sip. You can sip. She could have orange juice or something if she's diabetic. Anything else?
That was the only question that came in. Does anyone else have a question? You could raise your hand or type it in the question panel. Otherwise, we can move on.
Go ahead. Go ahead. All right. So I have these case studies. The first one I'm going to say is normal. But then you say normal. We used to do this in my training. We took a bunch of normal volunteers to get the baseline studies, but no, that's not what I was doing. I thought this was going to be abnormal. And so that's one of the usefulnesses of this series of studies is you can establish who really is normal. So the story is this. This is a 72-year-old male with a 1-year history of fecal incontinence, really consisting of smears. And he had a remote history of a fistulotomy. And for you that don't know, fistulotomy often involves dividing a little bit of the muscle that is overlying a fistula tract going into the anus. So he said he did Kegel exercises and he tried Imodium to kind of slow things down and dry things up, but it didn't work. On digital exam, I thought his resting tone was in the low normal range, but he had a pretty normal squeeze. So I was anticipating offering him something simple. I like the Seika procedure, which is a radio frequency waves. And I've had good luck with it. I know a lot of people don't like it, but it's at least probably, for me, 80% effective in reducing incontinence episodes. It's simple, it's outpatient, it's minimal risk, and it's cheap. So I said, maybe we could do this for you, but I'm still perplexed because you feel like you have a really good squeeze. Let's go ahead and check your manometry. So this is his study, and one of the things that I think is really useful is to be able to look at a study like this and get an impression. I mean, you can see right here, let's do rest first. Baseline, baseline, baseline. So it goes up, and that's right at 3 centimeters, and that's how long is high pressure zone, which corresponds with the length of the internal and external sphincter together in that cylinder. So yeah, that's within normal limits, 3 centimeter muscle. And it goes up pretty high. That's pretty good. That's a pretty good baseline. It doesn't look quite so good in the anterior quadrant. Especially in women, guys, you look at the anterior quadrant, it tends to be a little lower because the muscle's thinner there. And a lot of them have had old obstetrical injuries. So the squeezes are phenomenal. Let's go. That's a push. Whoops, remember what I told you about pushes. And above the sphincter, they're going to be high. So let me go into the sphincter. And here's a squeeze that's off the chart, way over 100. Squeezes are in red. Here's a squeeze way off the chart. So anyway, this computer spits out all the numbers, and its mean maximum rest or average rest is 38. Is that within normal? Yes, it is, 30 to 40. And the squeeze is 187. So, I'm not going to fault him for having a good squeeze. That's always a good thing. So that was acceptable. His rectal anal inhibitory reflex, I can tell you, is normal. His sensation was decent. The first sensation was a little off at 60 cc's instead of under 35. And the EMG pattern was normal. I think I have that. Yeah, that's a great EMG pattern. Now, here's a thing, a caveat. I told you have to look at the whole picture. He doesn't have outlet obstruction, like his puborectalis won't relax, which you would think about with a elevated push voltage. He doesn't have that. His symptoms are the opposite. They're a little smear of fecal incontinence. So some people, you have to think, okay, is this guy just having trouble pushing because I'm sitting here and he's in this position? This is very abnormal conditions. So I coached him a little bit, and because this is a tip to doing this study I found very useful. When I do the EMGs and you have the two surface electrodes there, they kind of rub against each other. So I put a gauze there. Then I'll tap my finger on top of the gauze, and when he pushes, I expect my finger to be pushed away. So if it's not happening, I'll just coach them and say, now you have to relax the pelvic floor. You can use your abdominal muscles, but make like a bellow, push my finger away. And on the second try, I do 2 runs for the EMG, by the way. On the second try, he did a little better. So I'm calling this a normal EMG as well. So what happened? So basically what happened is, instead of doing any procedures, I said, let me ask you about your stool consistency, because this doesn't make sense. If you have pasty stool, it is going to be difficult to clean up, and a lot of people find this issue of minor incontinence. There's also, if I may tell you, a situation where when I was in training, they did a paper on this called male pattern incontinence, and it's really smears the stool, maybe a little more, but it's the opposite problem that the woman with a weak sphincter has, and it's a long anal canal that's not as tight as it used to be, and poor consistency stool that gets trapped in the anal canal, and then when they get up and walk around, it seeps out, and they think that they're incontinent. But he didn't really have that either. We worked on his dietary management, no surgical procedure. So this is a summary, okay? And I want you to see how these studies allowed him to avoid surgery. And it also gave him the confidence that there wasn't a real issue with incontinence. Okay, I'm going to go on to this next one. I have possible short segment Hirschsprungs, because you'll see when we talk about this patient that she really could have had short segment Hirschsprungs. Now, what's Hirschsprungs? So it's an aganglionosis in that segment of the bowel. And it's, congenital. And the babies that you usually see them babies because they have a pretty extensive part of their colon that's not relaxing, and they get this big dilated colon above it, and they've got all kinds of problems. So, and have all kinds of surgery for it. But there's actually a short and an ultra short segment, which is just way down there right at the anus. And these people just have intermittent constipation or problems, lifelong constipation. So, this patient was a 61-year-old female, and she reported lifelong constipation. She had to take Miralax and other laxatives every day and strain even if the stool was soft. I'm going, okay, there's an outlet issue here. Emptying was incomplete, multiple trips to the bathroom. So what does that tell you? She sits down, she tries to go, sometimes she goes a little bit, but she certainly isn't empty. She gets up and goes back. And this is really unnerving to people who have an active lifestyle. They don't want to spend all morning trying to feel like they're empty to where they can, go on with everything they want to do that day. She had a normal vaginal delivery and a hysterectomy. Now, looking at her picture, her pressures overall, they look pretty darn good, right? And her in this particular channel, her rest is pretty good. Her overall average rest was 56. The high average rest, I call it mean maximum rest, and her sphincter length was 3 centimeters. Again, pretty good, right? Here's the 3 centimeter marker, and you see that's where the baseline goes up. So mean maximum squeeze 71. It isn't great. That's kind of like you expect it to be closer to 100. Now the thing about her is, I'm sorry, I have a sensitive mouse here. Yeah. Is I tried to get a rectal anal inhibitory reflex, and you can see in this first attempt at 30 and 40 and then 50, I did not get anything that I could call a reflex. Nothing good. And so I'm really thinking that she might have Hirschsprungs. Furthermore, we had the 25 cc balloon in there. She was not able to pass it. And her tolerable volumes were high. Compliance was high. And this is her EMG, which was also strange. She had a resting voltage of 8. This is 8. I could not get her to get it down. Squeeze 28 and push 14 and 28 on 2 tries. So the value of repeating it, I'll tell them this first one's a dry run. Okay, now let's do another one. So I was a little confused. Was this evidence of a non-relaxing puborectalis muscle? So we went ahead and followed this up with a defecography. Okay, so you look at this defecogram, and this is what it is. And again, if you know what it is, I apologize, but I'm sure some people don't. I do it the way I did it in training because I don't have, you can use MRI and you can use ultrasound and you can do fancier defecography, but you can do it simply with a fluoroscopy C-arm and a radiolucent commode chair. We use a PVC chair that you can use in the shower, and is mounted on a stand. And we use instant mashed potatoes and barium and mix it to a consistency that's about like oatmeal, and insert it with 2 Toomey syringes. So it's up to 120 cc's. I do put a little swish, probably about 5 cc's of barium contrast, liquid contrast, with air behind it to try to get it to coat the posterior vaginal wall so that you can look for things like the effect of this rectocele. Also, an enterocele would push the rectum down and splay apart the rectovaginal septum, which here is very normal. So I know a lot of people also on the defecography will give oral contrast. If I strongly suspect an enterocele, I will give oral contrast like an hour, hour and a half before we do the defecography, so all the small intestines is up here, opacified. But you can usually get a hint that there is a enterocele, which is small intestines pushing down into the septum and blocking the rectum. You can usually get that hint on the defecography without contrast. So I want to show you that this contour is a little abnormal. It should go like this. And here's the anal canal at the arrow. But instead she's got this big bulge. So she starts out with a big rectocele. So already I'm thinking, there's something. That's a good reason to have outlet dysfunction and to feel incompletely empty. So we go to the next step. This is with her straining. That rectocele becomes huge, but note also down here, her anal canal is not opening. Very poor opening of the anal canal, and is supposed to widen to about 2 centimeters, okay? And I did not see a puborectalis impression, which would be a notch down here, okay? The puborectalis sling goes here. There would be a little notch. I didn't see it. I mean, you could still have it and not always see it, and that's one reason I want to make a pitch for doing multiple tests so they all complement each other. So I'm like, oh my gosh, this woman does have Hirschsprungs. I am so sure of it. So I offered her a, here we'll go to the summary slide, if you want to read what we have already reviewed. I offered her a exam under anesthesia. I really can't do this on an awake patient myself. I just can't. Maybe somebody else could. They do have a suction biopsy that they use in children that you can do on them awake, but I did rectal biopsies. At the same time, I did a partial lateral internal sphincterotomy up to the dentate line, which is not going to hurt anybody who has full continence, and she certainly had full and excessive, if you would. So I did the sphincterotomy, and it's amazingly, the biopsies were negative for Hirschsprungs. But she did improve, also equally amazingly, she did improve with the sphincterotomy. So she's coming back and she says she has larger caliber stool and easier evacuation. And we talked about, geez, you have that huge rectocele. You know, I'm not sure that's going to empty well, but she was satisfied. So, I mean, one of the things about a rectocele and a elevated sphincter tone, okay, for whatever reason, but say somebody has a fissure and they have a really tight internal sphincter. Well, especially a woman who's had vaginal deliveries where the rectovaginal septum has been thinned out, if they strain against that internal sphincter, they're going to balloon that out. So it's sort of the chicken or the egg. In that case, I would fix the, I would address the sphincter muscle first because it's such a simple operation, and see if there's enough tone in that wall of the rectocele to permit it to empty more completely once the outlet obstruction is from the internal sphincter is dealt with. I hope you understand what I'm saying there. But anyway, so I would always do that first. I never say always, but I would think about doing that first. Anyway, the other thing about this particular patient, I think it illustrates the complementarity of the multiple testing, and that the exact etiology may be difficult to pinpoint but you can still treat for resolution of symptoms, starting with the simplest thing first, like a sphincterotomy. Okay. All right. Now this is a real short segment Hirschsprung's. This is a real one. So see if you can how this story, well, it doesn't compare so much because this patient's institutionalized, but some of her symptoms were very similar to the prior patient. This patient was 53 years old and institutionalized, pretty not severe, but moderate severe mental retardation. She had intractable constipation. The people who were working with her did not know how long she'd had it because she hadn't lived there all her life. Explosive incontinence. So it's like she would get backed up so much and then it would just overcome the resistance of the sphincter muscle and explode. She was not reliable for a history, and she was not really able to comply well on the to commands, for rest, squeeze, and strain. She had a normal colonoscopy. Now here's her manometry. And some things you can do. You might not be able to get a squeeze or a push really well, but you can sure as heck check the baseline resting pressures on a patient who's not able to comply. So we go over here and you see the baseline goes way up at about 4. Oh, well, here, wait, sorry. Yes, 3 centimeters right there. It goes way up. So again, a 3 centimeter sphincter muscle. Mean maximum rest turned out to be 96. So that's already markedly elevated. What's normal? 30 to 40. Hey, I wouldn't quibble about 50 or 60 in a patient that was functioning normal, but 96, you got to think, hey, that's a lot of pressure there. Mean maximum squeeze was only 98 because she really wasn't squeezing. I mean, here's a squeeze. Here's a sort of squeeze. And sensation was markedly blunted. Now, I'm going to turn the next page to her rare rectal anal inhibitory reflex. So you see something like this, and you're thinking, oh, that looks like a good reflex, but that's not where we were testing it. We were testing it right here. And she put present. That's a nurse. It's supposed to be absent. Look at another one. We're increasing the volume, 30, 40. And I'm trying it sort of at different spots in the anal canal. You really want the rare testing at the highest pressure inside the anal canal, because then you can note the biggest deflection with the relaxation. And this isn't it either, I assure you. We're supposed to see it right up here. And this isn't one, and this isn't one. So this is a patient I was convinced to go ahead and here's her EMG. Again, she doesn't really have any reasonable squeeze or push change because she couldn't do it. But her resting voltage is a little high at 7, which I think goes along with her problem. I did do a defecography on her, thinking, well, maybe this will show us more. And I don't have the picture, sorry. Her anal canal did not open up at all, and a rectocele formed, a small one. Okay. So we took her again under anesthesia and did an exam under anesthesia, biopsy of the low rectal wall, straight up for 4 or 5 centimeters, and I did a sphincterotomy because I had a reason that I could do it, even if she didn't have Hirschsprung's, similar to the other patient. I had a documented, markedly elevated resting tone. Now, she did have positive biopsies for Hirschsprung with an absence of ganglion cells in the submucosal plexus. So let me go back here. I think I have a summary on her, the institutionalized female. If you just read this quickly. And believe it or not, again, with the sphincterotomy, she did respond well postoperatively with spontaneous bowel movements. And that was a year and a half ago. So I recently saw her with worsening abdominal distension and some of the same problems. So I'm wondering, I mean, she could have a pull-through sort of procedure. I'm wondering if I would probably like to do a strip myectomy first, but I decided that I would restudy her, at least a defecography and maybe the manometry, just to be sure about what's going on and what changes there might have been. So I think that's kind of typical that someone would have initial good results with short segment Hirschsprungs to a simple thing like the sphincterotomy, but I'm not surprised that it's not long lasting. A strip myectomy is one of the simpler things that you can do for people with short segment Hirschsprungs. And instead of just slitting the internal sphincter up, what you do is you kind of make a tunnel in the intersphincteric groove and under the mucosa and grab it with a straight clamp and then divide it on either side so that you have taken out a strip of the internal sphincter. The issue is you have to get to the top of the muscle involved with Hirschsprungs or they'll still have a tight ring there. And that may account for the failures with this. Yeah, there's more aggressive and surgery like very low anterior resections or duhamels or suaves that you can do, which are pulling through the normal colon and reconnecting. Kind of complicated. This patient is Megarectum, and it illustrates some of the problems that you can see and why you might have false positive findings on a manometry, particularly with the RAIR, the rare. This is a 25-year-old female, slightly retarded, lifelong constipation. As a teenager, we had records that revealed she had a megarectum, but she was really non-compliant and never followed up, so there was nothing else done. She presented to me in July, October, and March of the following year with the biggest impactions I have ever seen. Massive impactions like a basketball in her pelvis. She was very small. I mean, she was very thin. So I would disimpact her under anesthesia, and then she would go home. I would give her some advice. I said, you need to come back. She would never come back until she was reimpacted. So the third time that I did this massive disimpaction, I just went ahead and did rectal biopsies. Again, from the dentate line to 6 centimeters above it. The results were initially equivocal. They had to send it to an expert in Dallas, and he did not think it was Hirschsprungs. She agreed to return, and she had a pelvic floor workup. So, again, not too surprisingly with her problem, her resting, her high pressure zone's about 3 centimeters. Up in here, you can see that. The baseline here goes up to about there. And her mean maximum rest was 82 centimeters. I'm sorry, 82 millimeters of mercury. And then the squeeze was 112, which is adequate. And I did not get a RAIR on her. I did not get a rare. So why is that? Let me tell you something else. We did the compliance, the sensation, compliance/sensation test. Her initial sensation was 400 cc's in that balloon. The first urge was more than 500 cc's, and I did not go any further because I was afraid it would pop. She has a megarectum. So when you do a rare on a person with a megarectum, the walls don't touch the balloon, so you can't get that reflex that you want to look for. So her EMG was basically normal with a resting voltage. This is 4, and a good squeeze, and then a 5 on the push. I did defecography on her. It is so thin because the rectum was so big. I filled, instead of 120, I filled 4 syringes, which is 240 cc's of the barium contrast with mashed potatoes. She formed a little rectocele, but when she stopped straining, it reduced. She strained appropriately, and ultimately the anal canal opened 2 centimeters, and nearly all of the contents were emptied. So I said, okay, well, let's see how you do. I can tell you, like I tell the normal patients on defecography, I can tell you that you can, you should be able to go to the bathroom and evacuate stool that's this consistency. Maybe your stool is hard like a rock. Maybe it's like dry clay or paste. That's not going to empty. In your case, you need all the help you can get. So we worked with her on a really good bowel regimen. I called her a couple months later, and she was still doing well with bowel movements daily or every other day and satisfied. So, and that was the last. It's been about 2 years since I've seen her. So interesting. Summary. Let's go over the summary. So again, 25-year-old female, chronic constipation, megarectum and non-compliant, massive impactions, and rectal biopsies were negative, and yet she had a no RAIR. Okay, again, you'd expect her to have poor sensation with a megarectum as well and increased compliance. So she did well with the bowel regimen. So, and here's a patient that I think you're going to find interesting. Patient was actually 86 years old, and I had a similar patient that was 94, a former anesthetist. And this gentleman had a several-year history of worsening evacuation of stool. He was normal until then, until he was 82. He used Miralax and said it has to be loose in order for me to get it out. No pain, no bleeding. I really dug for a history of a fissure. Did you have pain? Have you ever had a hard bowel movement where you felt that it tore? Have you ever seen blood when you wiped and it was tender? No, he didn't give me a history for that. He had a normal colonoscopy. He didn't have neurological disease. So I said, I don't know. Doesn't make sense to me. And on digital exam, it was very elevated resting pressures, and I felt a normal squeeze, long anal canal, I thought. So this is his manometry, and a long anal canal starts at 4 centimeters where it goes up. You can see it real well here. And you can see that these resting pressures are pretty high. Indeed, it was mean maximum rest of 126. That's one of the highest I've seen. Mean maximum squeeze of 169. So he had a good squeeze on top of that. I read the rare as present. I think this one you can say is present. It's a little small here, but on the tracing it's a little easier to see. And his sensation was a little blunted, but heck, he was 86 years old. And let's see, EMG. So, let me just say something about this. The value of the EMG, I do know a lot of places, even a place in Dallas and a place here in Tyler, where the GI people do the anorectal manometry, and they don't have EMG. So this very high elevated pressure could be a couple different things. It could be, the hypertonic sphincter. It could be anismus, and it could be, well, I have another patient with a neurological issue. So it could be a couple different things. So the EMG really helps to sort it out. And these next couple patients, I think I can show you that. So this is a virtual normal EMG study. So there's nothing wrong with the guy's nerves. And so what we ended up doing is a defecography. And I don't have all my defecography pictures because a lot of them were not great. The defecography was done to further evaluate the outlet. He had a normal rectal contour and anorectal angle. So there was no impression of the puborectalis muscle. Plus, he had a normal EMG. So that, to me, rules out anismus, non-relaxing puborectalis. But the anal canal did not open at all. Did not open at all. So I did, think about what you would do, elevated resting pressure, very elevated, normal EMG, anal canal didn't open. That was the problem. So I did a sphincterotomy. And it seemed to, as a best initial treatment, and it sounds like I do a lot of these, but I don't. I just sometimes it fits with this kind of outlet dysfunction where you don't have anything to lose because their pressures are already too high. And I contend that people that are fully continent, and by that I mean gas, liquid, and solid continent, can tolerate a partial lateral internal sphincterotomy. So he had great results. He came back and he was smiling grinning from ear to ear, as they say. I was a little surprised that he got so much good results with just that. But when I was at surgery, he did have a scar. I thought, oh, I think there is a scar here in the posterior midline, which is where we usually see that. Now, this one. This guy did have anismus, or non-relaxing puborectalis. His story is he's 76 years old. He was a diabetic. And again, instead of several-year history of difficult evacuation like the last patient, several-month history. history of pain in the buttock and inner thigh that was treated with chiropractic manipulation, but otherwise nothing that would draw you to have any conclusions up front. I thought his rest and squeeze were normal. But, and here's an example where the digital exam doesn't always correlate with these numbers. It certainly isn't 100%, but he had an average rest of, he had a twitch in his muscle. That's what he had. He had a twitch in it. The maximum average rest was 134, but I will tell you that the average rest below that was 80, which is still a little bit elevated. His squeezes were 196. Here's a squeeze off the chart here and here. He did have elevated push pressures inside the anal canal. So we see his high pressure zone starts at 3 centimeters here, and I'm going to find you an elevated push in the green. So here, this push is off the chart, and you know, here's a squeeze. Why should the push be so high when the balloon sensors, the catheter sensors are inside the anal canal at 1 centimeter? They shouldn't. So let's see what his EMG looked like. Well, he had what we call a paradoxical pattern. It's not what you'd expect. So normal pattern is rest 4, squeeze over 15, push about the rest. And every single time, and I did 3 times with him, had him push, and he had these kind of little twitches there, but it was definitely he could not relax that muscle. On defecography, here he does have what I considered a prominent puborectalis. Oops, well, not at rest. Let me show you with pushing. He has a slight puborectalis impression with pushing, and here's the contrast in the rectum. It's trying to get out. You see that it's flattening right here at the bottom, and it did not open up initially. He did a maneuvering and straining and pulled his feet up, and he was able to eventually empty well. So in conclusion, the way we treated him was with biofeedback. And he responded after like 3 treatments is all that he needed. And then you're going to say, why did he in the first place? When I was in my fellowship, we were taught that a lot of young people, like teenagers and young adults, might get the non-relaxing puborectalis because either they never learned how to defecate normally or they had some stress in their life. But I have no idea, neither does he, why he was not able to all of a sudden empty. But we were able to confirm this. And here I just try to show that the defecography was confirmatory, showing poor opening of the anal canal. The EMG here was very important because I wouldn't do a sphincterotomy on him. All we had to do is biofeedback. That's the treatment, initial treatment for non-relaxing puborectalis or anismus. And again, it was very successful. He actually called me to say I had 3 biofeedback trainings and I'm all better now. Now take a look at this next one. And I say elevated resting voltage. You know, we never really had a diagnosis on this woman. We never could figure it out. She has a neurologist that she's seeing for fibromyalgia and other issues. 55-year-old female with a 3-year history of constipation. It changed from normal to small ribbon-like stools only twice a week, even on amatiza. In order to evacuate, she had to use posterior vaginal pressure or digitalize, and that means posterior vaginal pressure, guys, is, if you don't know, very useful. If you have a rectocele, you can, they used to tell me, tell the patient that to try to use 2 fingers on the posterior vaginal septum. You insert it just into the lower part of the vagina and you push. It's really hard to use 2 fingers, but you can use your thumb and splint the posterior wall, like it's, you know, block it from ballooning out as you defecate, and it can work. Some people come in so desperate that they actually digitalize their anal canal to try to get the stool to come out. Now, I thought we had her figured out without any procedures, because with the fibromyalgia, depression, she was taking 4 hydrocodone a day, and she drank a gallon of tea and 4 sodas a day. I said, look, lady, that's your problem. But you know what? She didn't get that much better when she improved her dietary habits. Bowel movements became softer, but still required maneuvering when she stopped drinking caffeine, added water and fiber. On digital exam, I could feel a small rectocele. She couldn't squeeze very well. That's the other thing I noted, but I thought her resting pressure was normal. But here's her manometry. Sorry, that's her weird EMG. But here's her manometry. Baseline pressures go up at 3 centimeters. Again, it's a pretty common sphincter length. And mean maximum rest was 100 millimeters of mercury. Again, too high. The squeeze, 135, and the rectal anal inhibitory reflex was super present, if you would. So almost exaggerated. So it made me wonder if there's something neurological going on there. Sensation was decent, although her compliance was low. Her maximum tolerated volume was only 80 cc's. All right. Here's her EMG, which you already saw because I slipped. It's remarkable for one of the highest resting pressures I've seen, a resting voltage, of 20 microvolts. I tried a lot of different ways to get this lady to relax, recheck the leads, thought there was something wrong with them. And the defecography, this is a pretty normal contour. There's the rectovaginal, there's a contrast in the vagina, and that's normal rectovaginal septum. This is a pretty normal contour, except you see the beginnings of a small rectocele here and a nice tight anal canal there. Minimal lift of the pelvic floor with squeezing. We always look for the real pickup of the pelvic floor and accentuation of the anorectal angle. No evacuation of contents. None. She's pushing here. Push, push, push. Nothing. Didn't open up, not even a smidge. Then we stopped the filming and she used some posterior vaginal pressure and was able to evacuate some. I was really perplexed about this because I'd never seen that. I even went to some reference books. I couldn't find anything that would describe her condition. I called her neurologist. I described everything to her, and we said Botox. It's got to be Botox. So we did. We gave her Botox. Here's a summary. Elevated, dang, I have to fix that. It should be voltage, resting voltage, no evacuation, elevated resting pressures on the rare and pronounced rare. Something neurological here. So I used a whole bottle of Botox. Botox has 100 units in it, and it comes as a little powder, and you reconstitute it with 10 cc's of injectable saline. And the nice thing is that means there's 10 units per cc. So for certain things like anal fissures, most people don't use more than 40 or 60. For certain things, non-relaxing puborectalis, other things I'll use 80 or so. I used a whole bottle on her, all 100, injecting it into 4 quadrants. And she did super. I couldn't believe it. So this one illustrates the importance of the EMG. Also, the fact that her exact etiology, I couldn't give her a diagnosis. Maybe somebody out there can, but I can still treat her based on these findings. And the Botox wouldn't have hurt her with what we found. You know, when I do Botox for you know, all of these things, the anal sphincter, the non-relaxing puborectalis, or something like this, they may experience some fecal incontinence, at least temporarily. So I haven't had anyone with long-lasting fecal incontinence. You have to pick your patients right. All right, on to something slightly different, but you'll see. I'm sorry, that's my mouse. Let me get it back. Dang it. I'll ask for a new mouse for Christmas. I'm going the wrong way. Okay. All right. Sorry about that. There's a little break for you guys. This lady had full thickness rectal prolapse falling out of their anus, but we didn't know it. I mean, I couldn't see it when she was in the office. She was really uncomfortable. 66-year-old female with prolapsing hemorrhoids. That was a diagnosis she came with. 3-month history of fecal incontinence. All right. So this isn't necessarily constipation incontinence, but prolapsing hemorrhoids and incontinence, which it could be. You can be incontinent with hemorrhoids because they keep open the anal canal. On rectal exam, I thought her resting tone was normal. She did have a rectocele, and there was a clue. When you put your finger up there, pretty much to the hilt, you feel the rectal wall. And it can be thickened and ripply, like redundant. That's a hint that they might be prolapsing. Her manometry showed this. I wanted to sort it out. And it showed mean maximum resting pressure of 71. It's nice. It's above normal. A high pressure zone of 4 centimeters. Nice long muscle. And a squeeze of only 92, which wasn't great. But look at this again. Here's a push pressure here. The squeeze is low. Why? Because you're above the sphincter. Let's go into the sphincter at 4 centimeters. It's not so bad here. And a good squeeze. And here's a push that shouldn't be that high. And here's a squeeze. Okay? So there was a hint there that she might be prolapsing internally. I had 2 hints. I thought the rectal wall was redundant, and she had elevated push pressures, which should be pretty flat, this low in the anal canal. Okay, her sensation was slightly blunted with 60 cc's at the first sensation, and the other volumes were normal. Here's her EMG. All right. Now, what does this remind you of? Remember the gentleman with all the twitches who was recently constipated and responded to biofeedback? If you only had this to go on, you would say that's non-relaxing puborectalis muscle, send him to biofeedback, okay? But this is elevated because of that prolapsing rectal wall, okay? It's simulating a squeeze, if you would. I do have her defecography. You've probably already seen it, but let me just show you because it's very impressive. The one thing I would say about this up front, here's the rectovaginal septum's a little thicker, which makes sense, and then you have the contrast in the vagina. Now the anus is down here. Nah, actually it's over here. So you can get ready for that. She already has a formation of a fairly significant rectocele. It's a sort of bulbous rectum compared to that other patient I told you had a more sausage-shaped rectum, which I think is what I see in most normal people. So this is her push. It all disappears. Anal canal opens up. Look at that. More than 2 centimeters, really. And all that rectal wall with accompanying surrounding fat pushes the vagina forward. And here you have this characteristic funnel. Kind of looks like a little tornado up here, and a mushroom upside down here. And I can tell you what's happening because you can see it dynamically occurring. This is the contents of the rectal wall, so the rectal wall isn't visible, but it's here, that are pushing down into the lower rectum. And indeed, I checked her. I said, oh my goodness, something's happening, and I was able to see on examination that with the progressive straining, she was prolapsing outside her anus. So there are a couple different procedures for this, and people who are older, particularly if I feel like I need to fix a patulous muscle and I can do a levadoroplasty at the same time, I'll do it from below. So she had what's called an Altemeyer procedure and a levadoroplasty, and she had excellent results. So I'm only going to show you my excellent results, right? But she really did. She had excellent results in post-op. So that's the interesting thing about the elevated push pressures in the anal canal, correlate with the elevated push voltage. Defecography can confirm prolapse and rule out other causes like an enterocele with tissue falling out, and you also see that it's not a non-relaxing puborectalis when you put all of this together. So now we're going to go on to, I have 2 more, guys, if you're hanging in there, and I'm going on to incontinence or the pudendal nerve, effects on the pudendal nerve. And this is a patient who is 67, 2-year history of fecal incontinence, daily fecal urgency, and weekly episodes of incontinence to soft stool. Now, that's not so bad. Usually when we're going to fix somebody's sphincter or address it in some way, they should be having at least 2 episodes of incontinence a week. She had a history of a remote vaginal delivery with twins. Now, twins is one of the things that can contribute to stretch of the pudendal nerve, and forceps deliveries and long deliveries are things that make you suspect a pudendal nerve injury during the obstetrical phase in this person's life that can manifest later with all other things that go on. And she was diabetic. She already had some early peripheral neuropathy in her feet. On exam, her anus was slightly patulous. Resting felt below normal. Obviously, with a patulous anus, you're not going to get much of a grip. And I could not appreciate a squeeze. So you say squeeze, pinch, pretend you don't want to pass gas, do whatever, nothing. So on her, interestingly, her mean maximum rest pressures were within normal limits at 51. Here's her baseline. Those are good pushes. And then it goes up here. And that's the average, the maximum average across this was 51. And her high pressure zone was also decent. She had a decent muscle length of 3 centimeters. Right there is where it goes up. Her squeeze was only 69. So why does she have a squeeze at all if she doesn't? Like if I didn't feel it? I think people can recruit their gluteals, and sometimes you get a squeeze that's coming from outside the anal canal. So sometimes you'll get a little minimal squeeze above the rest when they really don't have much squeeze at all. Her rectal anal inhibitory reflex is not on here, but it's normal. Her EMG is this represents 7, and the main thing is that I don't know why it's so high, but the main thing is this is below 15. So to me, I don't have, and I haven't shown you one pudendal nerve terminal latency. I don't have it. That's just it. I can infer, and again, I have to use this kind of thing, the voltage on the squeeze. I can infer in conjunction with the whole picture that she definitely has a pudendal nerve injury. Now, she was in the phase of early dementia, and her husband was making all her decisions. We decided to work on stool consistency, and if she really needed something down the road, then we would consider it. Supporting the pudendal nerve damage from diabetes, and maybe contributing to damage earlier in her life from the childbirth. All right, one more. This is a very nice lady who was 55 years old and had moderately severe MS. She was already having difficulty with ambulation and documented bladder outlet dysfunction. She presented with constipation. You'd think, oh, is she going to be incontinent? Well, you can present with either one, but she would go days without BM and have to digitalize frequently. On exam, I thought she had a normal resting tone, was good, but not squeezed at all. And that pretty much correlated with what we found. Her high pressure zone, again, about 3 centimeters. You can see it really take a increase here. Manometry showed a resting pressure of 50 millimeters of mercury and a squeeze that was not much higher than that. I'll show you a couple of those. Here's a squeeze a little higher than the rest. A squeeze a little higher than the rest here. So she actually had decent intrarectal sensation. This was only my second MS patient that I evaluated. Her first sensation was at 40, and she did not have good compliance. Her maximum tolerated volume was only 160. Her EMG is impressive. The resting is 4, and we said 4 is normal, but nothing else happened. It's just like a flat line. So this is one of the typical patterns you can see with nerve damage from multiple sclerosis. And all I really had to offer her was a bowel regimen, including enemas and occasional suppositories. I always like to try fiber, bulking up the stool, because it's the easiest kind of consistency stool to evacuate. I did a little research for her, and she could have considered Botox, but she decided not to. There would have been a risk of incontinence with that too. So that's all the case studies. Oh, I'm sorry, I forgot to turn to this. So recommend bowel regimen, some evidence that Botox could help. This slide is outdated, Kim and I decided, but we don't know what the new numbers are. But looking at RVUs, this series of studies, actually, I think it does pretty well, especially if you have a very, very, I say very, reliable nurse or other person doing the procedures, and you're the physician, and you just have to read them and make a summary. I think it's a pretty good deal, actually. But they're valuable tests. They really are. So in summary, anorectal manometry is a cost-effective study that can improve patient care. And the Solar ARM is a platform that allows you to perform full pelvic floor diagnostics and rehabilitation. And that's that part. I just have something to illustrate to you. The techniques, the steps you go through are super, super well written down. So and we just use it every single time, so we don't skip anything. And here's the other part of those tests, rare sensation and expulsion. So let's just talk about some of the other things besides what you would get from LabArray that could augment your evaluation. And we talked about defecography. I won't mention it again. It can be useful with incontinence, but not gross incontinence where that's all the patient has. Remember, you can have some incontinence without lid obstruction, and that sort of picture, sort it out better with defecography. There's a rectal ultrasound that I use for incontinent patients to determine if the tears are present, and if they're significant or widely separated enough, and you can use that to decide if they would benefit from a sphincteroplasty. We used to do sphincteroplasties a lot more liberally than we do now, and we have other methods, and then the sacral nerve stimulation as well, which allows you to skip the sphincteroplasty step if it's not a wide tear, and it's just less morbidity. Colon transit studies. Patient swallows a capsule containing 24 radiopaque markers. I just use the simple guidelines that the company recommends. You can do very detailed analysis or segmental of the transit through different segments of the colon, but I just use a regular one, and after 5 days, 80% of the markers should be gone. It's very important for me to look at the pattern, because you'll have the retained markers, and the radiology report will say 24 retained markers, evidence of colonic inertia. And my goodness, you look at it, and every single one of them is in the sigmoid colon or in the rectum. Now, that's not evidence of colonic inertia to me. And also be aware, a lot of patients who do have bona fide colonic inertia because of straining, because of whatever, and the contribution of the pelvic floor dysfunction to their constipation, they will have internal prolapse or something else going on, but usually they'll have internal prolapse along with. So the pelvic floor studies should always be done in a patient who you think has, idiopathic constipation or colonic inertia prior to considering a colectomy on them. Okay, an example: diagnostics and therapy in incontinence. So you may want to do the anorectal manometry, rectal inhibitory, reflex, balloon sensation, expulsion, and EMG. You might want to check their pudendal nerves. That could be very helpful. Do an ultrasound, and if symptoms are combined with constipation, defecography. Treatment, always first. I consider I'm kind of like a less is more person, so I'll say, and it's a little labor intensive to sit down and say, what is your stool like? How much fiber do you have? What do you take? Here's a food diary. Maybe you could fill it out. Here's a fiber sheet. I want you to try half an Imodium every day and then titrate it. So you work with them and have them come back in a little while. A lot of patients don't do a very good food diary, though. So and a lot of patients will be done with this. A lot of the incontinence I see is diarrhea. Of course, I mean, lots of normal people would be incontinent if they had pure liquid stool. So say that doesn't work, then you can do, we have pelvic floor rehabilitation that would be like biofeedback. I don't have that availability where I work. In fact, if I have a non-relaxing purectalis, I have to send them to a city 45 minutes away. But the physical therapist there is fantastic and actually studied pelvic floor physical therapy at Baylor. SECA is one of the things I've referred to, which is simple, and it involves little wire prongs which go into the anal canal, and they deliver radio frequency waves which draw up or pucker the muscle. They do not scar it. It's been documented that it's like when you fry an egg in a pan, it draws it up. So there's an effect of tightening. I've had some patients where I could really tell the difference afterwards just in the resting tone. I've had patients that I haven't. They say it's 80% of patients will get 50% improvement. So if they go have to change a pad or a diaper or whatever twice a week, then 80% of them will have an improvement to where they only have to change it once a week or better. I've had patients be cured with the SECA. Celesta is the injectable underneath the in the submucosal plane of the anal canal. It has the same kind of results of 80% get 50% better. What I've found with fairly limited experience is it's real hard to get the insurance to approve it, but also Medicare will approve it now. But also 50% of patients need a second application. So let me try to illustrate this if you haven't seen it. You inject this little substance underneath the mucosa at 4 corners, okay? But you still have space in between corners. So half of the people will benefit from doing a second injection in between the first. So now you have all these little pads of permanent gel, if you would, touching each other. Sure, you'd think that'd be more effective, but it's 2 applications of a fairly expensive product, and still it's not going to work for everybody. I've had, anecdotally speaking, to a colorectal surgeon where they actually used it when the patient had a fistulotomy and they were leaking out of that fistulotomy crack, kind of like out of a keyhole, and they were able to use Celesta to fill that, so it may have applications like that. Sacral nerve stimulation is like people have spinal stimulators, and the sacral nerve stimulation for bladder incontinence is the same, which is convenient, because if they have bladder incontinence too, you can more easily find a urologist who's implanting these than a colorectal surgeon who is. And it has good results. If the patient passes a test phase, it has very, very good outcomes in the permanent phase. Anal encirclement, we used to use, nobody uses Church wires anymore. You actually do a wire to prevent incontinence or inoperable patients who had rectal prolapse. You used to be able to use a silicone band, but as far as I know, I've tried to get one, and they don't make them anymore. DuPont was making them, but they don't. There are other people working on that, and I guess I was up here. Sorry. Yeah. There's a ring of magnets that's kind of an elegant design and sort of promising that I think is in trial phases. And the magnets, hold together and keep the anus closed. And when the patient overcomes that resistance with, pushing at defecation, then they're allowed to empty. So we'll see how that comes about. Constipation. Always start with high fiber if they can tolerate it. The people that can't tolerate it are the people with colonic inertia. Increase their water, 6 to 8 glasses. Watch their caffeine intake. Talk to them about that. It can make a difference. Then I do fiber water stool softener. That's usually the first line. Add Miralax or MOM, depending how they feel. Magnesium tablets also work pretty well. Then there's Linzess, Amitiza, etc. The workup can include, just like we talked about, the whole battery of manometry, rectoanal inhibitory, reflex, balloon sensation, expulsion, EMG. Often should or will include defecography, may include colon transit study. And we've talked a lot about the treatments non-relaxing puborectalis, pelvic floor rehab. I've had patients who this did not work for, and I've gone back to use Botox on them. Partial internal sphincterotomy if distal pressures are elevated. You can fix a rectocele transanally or transvaginally. If they have symptoms of difficult emptying, I advise it to be treated transanally because you can better flatten that wall with application, rectal prolapse repair, etc. And subtotal colectomy is taking out all of the colon down to the rectosigmoid junction and attaching the small intestines to it. And that's everything I have. So thank you very much for your attention. I hope you lasted, and I'd be happy to entertain any further questions. Hopefully I can answer them.
Dr. Callie, there was a question that came in earlier when you were talking about that hypertonic study.
Yeah, sure.
The question was, and the person that asked the question isn't on anymore. He dropped off a little bit ago, but I'll ask you anyway. Okay. Why might you choose to use the high-resolution arm testing versus using the TDOC catheter? He asked this question around the time that you were going over that hypertonic.
Oh, I see.
Case.
So maybe he was just thinking about it. I think it's preference. I think the high-resolution manometry as opposed to regular manometry, which is all I have. Or is that what you're asking?
Well, I knew that, but I'm not sure.
No, I mean, I think it's personal preference. I think most everybody's going to the high resolution.
Okay.
Make because it's just visually, you don't have to do what I was showing you guys to do to look at for in a way it's for those who are not as initiated, if you would, and. For me, I really do have to study the curves, and I sort of make it in my mind. But for high resolution manometry, it's right there, the full picture, the 3D image, and all of the pressures at once. So it's just the kind of the way most people are going. It's new and improved.
Okay.
Sorry.
Okay. Very good. Does anyone else have any questions before we end the session? It appears like not. But this was wonderful. Thank you.
No, thank you. Thanks for everybody paying attention. It's a lot of information at once.
It is. Okay, well, with that, I guess we will say good night. And thank you again. Thank you, Dr. Callie.
You're more than welcome. Thank you, Kim.